This is Ahmad, and today I'm going to present my Mitchell Prize presentation entitled Risk Factors for Eye Removal Surgery in Patients with Endophthalmitis. Thank you to my mentors, Dr. Fu and Dr. As we all know, endophthalmitis is an infectious condition of the intraocular contents with the potential for catastrophic effects on the eye. Due to its high risk for causing blindness, as well as the potential risk for systemic infectious spread, endophthalmitis has historically been a common indication for eye removal surgery. Specific objectives of eye removal in endophthalmitis include source control during acute infection, or for pain management or cosmesis in chronic or resolved cases. Prior to modern antibiotic and surgical treatments, eye removal was often the only effective treatment for acute endophthalmitis. However, newer surgical and antimicrobial options have reduced the rates of eye removal in endophthalmitis to a range between 14.3% to 23.2%. Factors that have been previously associated with an increased need for eye removal surgery in endophthalmitis have included corneal ulcer or endogenous source of infection and poor initial visual acuity. However, prior studies have been small and only looked at the need for eye removal surgery in the acute setting. Also, they did not look at a wide range of clinical and treatment tactics. The purpose of our study was to characterize the risk factors for ultimate eye removal surgery in a large cohort of patients with endophthalmitis from an academic institution in the United States. A better understanding of these characteristics may aid in identification of patients who would benefit from more aggressive treatment, such as earlier salvage surgeries like PPVs or therapeutic keratectomy. On the other hand, knowledge of risk factors for ultimate eye removal surgery could also assist in patient prognostication and counseling with earlier intervention in sick cases of severe ocular infection. We were also interested in the differences in characteristics between those receiving different kinds of eye removal surgery. We performed an EHR-based retrospective chart review of adult patients seen at the Wilmer Eye Institute with diagnosis of endophthalmitis based on ICD-10 diagnosis code between January 1st, 2010 and September 1st, 2019. Inclusion criteria was patients aged greater than 18 years old and at least one visit with any provider at our institution for which the primary diagnosis was endophthalmitis. We excluded patients with a pre-existing diagnosis of endophthalmitis that had been treated outside of our institution or those in whom a diagnosis other than endophthalmitis was suspected by the primary ophthalmologist. Clinical data was recorded including demographics, length of symptoms, pain at presentation, and final exam characteristics, endophthalmitis cause, microbial culture results, surgical and medical interventions. For patients who underwent eye removal surgery, surgical details and timing were also recorded. Chi-square and student t-tests were used to identify which clinical factors predicted eventual eye removal surgery. ANOVA was used to detect differences in frequencies of causes for endophthalmitis between the two groups. Multivariate analysis is under. 25 out of 253 patients, or 9.88% of patients with endophthalmitis that were identified, underwent eye removal surgery from 2010 to 2019. The table here shows differences in clinical characteristics between the two groups. On presentation, patients in the eye removal group were more likely to have pain, poor visual acuity, high IOP, and an RAPD. They were more likely to have a corneal ulcer, keratoprosthesis, trauma, or combined causes for endophthalmitis, and less likely to have a recent injection or surgery, remote glaucoma surgery, or endogenous causes of endophthalmitis. They were likely to have fewer tap and injects and fewer pars plana vitrectomies than those who did not receive eye removal surgery. Final ocular characteristics were significantly different between the two groups, with eye removal patients tending to have more pain present, worse final visual acuity, and were more likely to have an RAPD at the final visit. Here is a graphical representation of the differences in visual acuity at different time points between the two groups. There was significantly worse presenting and final visual acuity in the eye removal groups compared to the eye salvaging group. Of the patients undergoing eye removal, there was an equal distribution of enucleation and evisceration performed. There were no major differences between the two groups undergoing the two different surgeries, except that enucleations were more likely to be performed as primary surgeries, which we defined as within 1 week of endophthalmitis diagnosis, than eviscerations were. There was a roughly equal distribution of implant placement, and a significant portion of patients did not have an implant placed in the study period in the evisceration group. Simple and multiple logistic regressions showed significant variables predicting eye removal to be RAPD, tap and inject on presentation, MRSA, endophthalmitis, baseline visual acuity, presenting visual acuity, and presenting IOP. After multiple logistic regression, baseline visual acuity approached significance with a p-value of 0.052, and patients with MRSA endophthalmitis remained highly more likely to undergo eye removal surgery compared to other pathogens. In conclusion, we found that less than 10% of patients at Johns Hopkins with endophthalmitis undergo eventual eye removal surgery at our institution. Patients with endophthalmitis who undergo eye removal surgery have more severe presenting disease, including worse visual acuity, worse intraocular pressure, presence of RAPD, and undergo less aggressive salvaging therapy. They also have a distinct profile for endophthalmitis cause compared to those who did not undergo eye removal surgery. We also found on multivariate analysis that MRSA endophthalmitis may be an independent risk factor for eye removal surgery in patients with endophthalmitis and may help in prognostication in these patients. Thank you to everyone who helped me with this project, and I'm happy to take any questions. Thank you.